3 hours later. So again, we have to go fast, even with this treatment, which is still effective after a few hours. But even in this case, if we can treat the patient after 1 or 2 hours, this is a few common points. They randomize patients after 6 hours, 24 hours in down, 16 in diffuse. They made a comparison between thrombectomy and conventional match between a high NIH and a small core. So this is easy. You have an NIH at 25 and a small core, for instance. And in diffuse, it's a mismatch between perfusion and diffusion imaging. And both showed that there is a mismatch. So this is very important. That means that all patients who have a stroke with a clear onset within 24 hours are patients who should be managed in emergency. Even 16 hours after onset, it's still in. We had a call for a patient who started 5 or 6 hours earlier. We stopped, said it's too late. Now we cannot do like this. So we have recommendations for that. You have here the recommendations for interventional care, the European one, published in Europe. Few of these recommendations should already be modified. It has been published a few months ago, and we have already to modify them. For instance, we speak here of the time window, which is 0 to 6 hours. This should be modified. It should be 0 to 24 hours. This should be modified also. This is, again, something concerning for thrombectomy. The decision of thrombolysis and thrombectomy should be taken at the same time. So we can decide thrombectomy on the first CT or MRI. We have not to wait. And in a few patients, thrombectomy is a first line. And finally, decompressive surgery. This is not something we like to do because when we have to do a decompressive surgery, that means, but sometimes it's the first treatment we can give, especially in young people. This is an old CT scan. I think it's one of the last patients we had maybe more than 10 years ago. It's a patient who developed unuseful to perform surgery at this stage. It has no sense. And decompressive surgery provides no benefit if you have an increase in intracranial pressure or clinical worsening or something like this. Decompressive surgery works only, in fact, at risk of being malignant. So the decision to make the craniectomy should be taken before you have a malignant infarct, when the patient is still well, hemiplegic but well, and the craniectomy should be large. This is good. This is a large trauma of the brain. This patient was reoperated after. It was one of the first one. It's effective. It reduces the risk of death. You see the difference here. 71%, it becomes, I cannot imagine that these patients with huge infarcts will recover completely with a ranking 0 or 1. This may happen, but in very rare patients. And you can see hemicraniectomy. This is a crucial question. Hemicraniectomy, I think the number you have to bear in mind is 145 cubic centimeters. They should be operated. And don't wait worsening of the patient. The only exception is if the patient is very old. There is still a benefit after 60 years of age, but of course it's very unlikely. If you have no MRI, if you cannot have MRI immediately, so if it's difficult, it can be evaluated with a CT scan. In the 3 trials, in the Dutch and in the German trial, CT scan was allowed. So it's the same interpretation. You have no volume, but if you have a large ischemic stroke, and the benefit is very small, but we have seen that as we can treat a lot of people, we have a benefit at the population level. And of knowledge of stroke symptoms in the community, and we may have public campaigns like this, but these campaigns should be repeated, otherwise it's not useful. Many people do not know or are not they should not call the GP. And so we have to make campaigns with the GP, saying in case of stroke, don't call us, call number 15. Sometimes the bottleneck is a lack of priority for ground transportation. Days are increased because other people have to go. The lack of pre-hospital notification, this happens when the patient did not call the emergency number, or sometimes this may happen if you have a stroke chameleon, so a stroke which is not, where the features are not stroke features. In this case, of course, you will not be notified. If we have no direct admission to CT or MRI, this may be a problem. So these hospitals are usually organized to have arrival of the patient in the if we use telemedicine, maybe the STEMO system, and of course if we have this notification, because in this case we can have CT or MRI available. And this is a very important picture. It has been published in a German journal. In the paper there are two different figures, one with the rate of thrombectomy in hospitals. And when you see this picture, I don't know why I did not put here. When you saw this picture, you say, oh, there are areas in German level, because you can be in an area where there is no center to perform thrombectomy, but in connection with another center where the mechanical thrombectomy can be performed. And you can see that with a few exceptions, here, for instance, in white, the territory, a key factor of success. So we have to work with the population, we have to work with the emergency physicians to earn time. Time is everything. It's maybe more important than the drug you use or time. We have more benefit from these treatments and we have less complications of the treatment. So it's a benefit for everybody if we can earn time. And to reduce delays, it depends on the level of education of the population, on the possible way from home to the stroke unit. Everything should be organized. Who will go home, where will arrive the patient, and how to proceed, who is making what, for instance. This is the key factor of success. Thank you for our chairman.
Thank you. I have a question about acute angioedema. Is there any risk to have this side effect also with tenecteplase?
Excellent question. Actually, does not exist when you give TPA for something else than a stroke. And in a stroke, to have an angioedema, you need to have an involvement of the insula, and you know the role of the insula in the vegetative, it's known in epilepsy, for instance, and so on. So but the number of patients treated in trials is very small. We have to be wise for that. It will be a huge benefit of tenecteplase, especially now because we have these patients who are admitted in a stroke unit without thrombectomy, and having an angioedema during this transportation is something which is dangerous, probably.
More questions?
Neuroradiologiste, neurologiste, chirurgien. Quelle est l'expérience en Europe, en Amérique du Nord, au Japon? Quelle est la règle, quelle est la loi?
The question is, who is allowed to perform thrombectomy? Is it a neurologist? Same rules in most European countries. I will speak of the French experience. To be allowed to perform thrombectomy, you need to have been trained in radiology for at least 2 years. But it's not something which is specific for a specialty. So it can spend 2 years full-time for that, and can do, they have the habilitation for interventional radiology. It's usually for coiling, and neurologists usually don't perform. To know if we will allow cardiologists to do also. Many people are reluctant because it's not just a problem to go in the vessel and to remove the clot, it's also the problem to know the brain, and the brain is not the heart, it's not the same. Personally, in this case, why not? But this may be something which is dangerous. I don't know in Austria or in Germany, what is the position now?
Yeah, I can just talk for Austria, not for Germany. In Austria, we have one center. I think you have have a sufficient number of thrombectomies performed, and I'm also actually very hesitant with cardiologists. I mean, not if they would work in conjunction with neurologists, but I think the places where they try to take that over is where there are no neurologists, and I think.
We do have too much neurologists and too much neurosurgeons, and therefore there is some competition also.
Cardiologists do not know lacunar infarcts, for instance.
There are no European guidelines for that?
There are guidelines, but they are quite general. Cardiologists want to spend 3 years in a stroke unit, to work full-time in a stroke unit. Why not? We will not say no just because he's a cardiologist, but he has to become a stroke physician, for instance.
What about thrombectomy for minor stroke?
We have to treat these patients. For thrombectomy, usually we have a threshold around 4, but we have, also, of course, to evaluate what is the risk, because in a teacher, personally, I will go to with an occlusion. I will go to thrombectomy because it will be a drama for this person to have a problem with the length of the day in an armchair or something like this. We have to evaluate case by case in this case.
Yeah, perhaps I would just like to add to that. I think what we should also consider that this may be just a situation that is still maintained blood flow with collaterals, and that these people may worsen. So if
time we treat more and more patients, and probably we will not have this question in the future.
Pour les thrombolises au-delà de 4h30, est-ce qu'il faut toujours passer par un mismatch de...
If TPA after 4.5 hours, is it absolutely necessary to have MRI and to have a mismatch between diffusion and perfusion, or can you use clinical mismatch? If we go over the time window, the usual time window, 4.5 hours for thrombolysis, 6 hours, quickly straight to thrombectomy without thrombolysis, because we may have a risk. In other cases, if we do, what is very important, I think it started at this time, but actually this is wrong. And if you have somebody with a deep deficit and a very small radiological mismatch, could be okay. Yeah.
Yes, sir.
But most of these patients will need thrombectomy, actually.
In lab with the special case in persistent mismatch.
You mean if you are in an hospital where thrombectomy is not feasible?
Yes.
And with a too long delay to refer the
Yes.
patient? Yeah.
And
who was a professor of neurology in Lyon, and is still working in some countries in Africa, in French-speaking Africa, recommend this, but it's not evidence-based. I have no experience.
Voilà. Il y a juste une question par rapport à la craniectomie. Donc, vous avez parlé de tout ce qui est AVC et Sylvien Malin. J'aimerais que vous nous parliez un peu des AVC de la fosse cérébrale postérieure, notamment les AVC cérébrales. Quand est-ce faut-il... on sait qu'il n'y a pas de limite d'âge, il n'y a pas de limite il n'y a pas de timing, mais quand est-ce faut-il s'alarmer? Et aussi la fosse...
The question is...
donc, il y a le cervelet et le tronc cérébral. Est-ce que le cervelet, c'est connu? Le tronc cérébral, est-ce que vous faites une craniectomie?
The question is, you spoke only on malignant MCA infarct and not on of cerebellar infarct and brainstem infarct. So I will answer on this. For cerebellar infarcts, we have no trial. I think we will never have trials, but to a neurological department. So for patients, if we see, of course, a clinical worsening, sometimes this may happen quite rapidly, or if we after 5 days, there is no risk anymore. If the patient is after 5 days, there is no risk. For brainstem infarcts, usually in brainstem infarcts, we have no malignant infarct. So it's or it's secondary to a cerebellar lesion with the compression of the...
Compression was always something that we did immediately. Yeah, I think it's
Because
better than ventriculostomy. Yeah.
When I was
Aspects of training across Europe and the Mediterranean, and we are very much looking forward to your presentation.
Hello, everybody. I'm so delighted today to be representing the RFS community, and I think this is a big opportunity for me, so I can inform my colleagues and all the junior trainees present here today. Try to consume only the resting time I have. I'll be introducing firstly the RFS community, talk to you about the educational opportunity. I will give you a small side to the history of the European Academy of Neurology and, of course, of the RFS. Firstly, there was the creation of the European Neurology. After that, there was the creation of the and at an international level, and also to help juniors who are interested to spend to get some clinical training or research to spend time in other countries, to improve the training of neurologists by learning from the others, other experiences, and connecting young neurologists. For Giovanni is the secretary, Vanessa is the new treasurer, and Anna is the past chair. Actually, it goes like this. We firstly, every year, select a new treasurer, and European Academy of Neurology, the committees, the educational committees and scientific committees. And I think the major aim is to be as young neurologists and young trainees involved in the development of neurological guidelines. Another, there is some available positions. Actually, to be a representative in a scientific panel, you have to be an RFS form, and we meet all the representative members and the members of the scientific panels with the professors, and during the EAN congresses or in between. As a national representative, the major aim is to inform the regional and the national community of juniors about the available grants and teaching courses and spring schools and congresses activities. To become a duration is in general decided by the National Junior Society. So, what about the last one was in Lisbon, and the next one will be in Oslo. Sorry, all welcome. And as RFS member during the Congress, silly pictures. Sorry, I didn't take your approval to post this one. So, and after this, we go to visit the university hospital, and we did meet with the professors there. We have had some news about the. I will encourage you, of course, to go to your Facebook page and like our RFS Facebook page. You will get informed about the latest student, or having at least your degree, none more than 3 years. You have either the possibility form. What do you get if you are a member? Actually, there is many advantages. You have one. This is two things in the area at the EAN Congress, and you have reduced fees at the, of course, of the EAN Annual Congress, and of course you have the access to the associative or associate the European Journal of Neurology membership fee, and you have also free online access to the European Journal of Neurology, the online learning platform eBrain, and the EAN guidelines and the EAN educational grants. It's only 25% per year, 25 euros, sorry, per year. And for of the European Academy, you can have more information schools. There's the annual autumn school. The last one was in Greece, and it was about loss of consciousness and great the topic will be this. The next one will be about stroke, higher cortical functional teaching courses. In general, they are about basic teaching in neurology. It's a 3 days course in English, and October, it was in Madagascar. It was about epileptic seizures and epilepsy, movement disorders, spinal learn, and click on eBrain. You have access to the most comprehensive web-based training resource. It's considered to be the world's largest one, and you can have some. You can find there some interactive online learning, and it covers all the fields of neurology. Fellowships. So about the fellowships offered by the European Academy of Neurology, you can have more information if you go on Learn, and fellowships and funding, and you are eligible if you are a resident of neurology or you have completed your training within the last 3 years. Hesitate to fulfill the application form. What about the available grants? Actually, the European Academy of Neurology gives so many grants and bursaries. There is one for attending the Congress, the annual Congress of the European Academy of Neurology. You can just go on the website, click on Inform Accommodation. You are eligible if you are a PhD student or a resident in neurology. And you have to have an abstract accepted in the annual Congress. This exam, it's a structured examination which helps to harmonize the postgraduate training of neurologists and sets European standards. It leads to a qualification, and it's an additional sign of. There is some dates I would like you to remember. The annual spring school deadline. The next one will be in the 31st January 2019. The European Academy of Neurology Congress, the next one will be in Oslo, and the research fellowship deadline. So I will finish by tell you about actually a small souvenir I had with getting the young neurologists involved in this community. I thank you so much, sir, for this, because it gave. That's all. Thank you so much.
Yeah, thank you also very much their supporters. Are there any questions already now to Dr. Diba? No, so please just follow her advice.
From the EAN, interesting questions also. So I think it's time for lunch. And before Jawed, for the photo, it's outside. Alex.